and I'm going to be talking about a few of my favorite things, some research highlights from residency. So I have no financial disclosures. So just like in The Sound of Music, I wanted to share two very important aspects of my own life and two of my favorite things. The first is my family. You can see in this picture on the left, my husband Avi and my daughter Rachel, who you probably heard throughout the evening today. And the second is, like many of us in the audience, my passion for ophthalmology, specifically cornea. In a couple of weeks, I'll be starting my cornea fellowship at Bascom Palmer in Palm Beach Gardens, and I'm really excited about that. And the two topics that I'll be discussing today really highlight these two very important aspects of my life. So the first project is adverse ocular events related to antibody-drug conjugates, and I want to thank my co-residents Nikita and Phil for their help with this project, as well as my mentor Dr. Farouk, and our collaborators at Vanderbilt Eye Institute and Mercy Eye Clinic. So just some background information, antibody-drug conjugates, also known as ADCs, are a very exciting new class of medications in oncology. And there's many different applications for antibody-drug conjugates, but every type of antibody-drug conjugate has three components. The first is an antibody, which is specific to the tumor cell and that targets antigens expressed on the tumor cell. Connected to the antibody is a linker, and connected to the linker is a toxic payload, which is delivered to the tumor cell once the drug is capable of entering the cell. And you can think of antibody-drug conjugates kind of like a Trojan horse, where once the drug enters the cell, it's capable of wreaking havoc within the cell, ultimately destroying the tumor cell. And there's many different antibody-drug conjugates, but I'm going to be talking about two that we have researched over the past several years. So the first one is called tisotumab vedotin, also known as Tivdak. It's used for patients who have refractory cervical cancer, and it's well known in the literature to cause mild to moderate ocular surface disease. Less commonly, it can cause moderate to severe ocular adverse events. And we recently published a case series of 5 patients who had these more moderate to severe adverse events from Tivdak. And so some of these patients developed subepithelial fibrosis, which are these fibrotic bands in the conjunctiva seen in severe ocular surface disease. Several patients developed keratin, which you can see on the photograph on the top here, which is this whitish material also seen in ocular surface disease. One patient developed symblepharon, which are these fibrotic bands on the conjunctiva, also seen in ocular surface disease. And then several patients developed bacterial conjunctivitis, and one patient actually developed a very severe form of infectious keratitis, which is an infection of the cornea that actually required a therapeutic corneal transplant. And what this project really highlights is the need for communication between ophthalmology and oncology, and for close observation for these patients who are undergoing treatment in order to ensure that these patients are adequately monitored while taking these medications. And this really brings us to our second antibody-drug conjugate. Using what we learned from Tivdak, we applied similar principles to a different antibody-drug conjugate called belantamab madofen, also known as Belamaf. And this is an antibody-drug conjugate that is approved for patients who have relapsed or refractory multiple myeloma. And just like patients who take Tivdak, patients who use Belamaf also have been shown to have a variety of different ocular adverse events. Most commonly in clinical trials, they have been shown to have these pseudomicrocysts, which you can see on the photograph on the right. They're these tiny cysts that are seen inside the cornea, and they can be pretty visually significant for patients, so it's important to consider them during the examination. And they can be so severe for some patients that there have actually been ocular toxicity scorings that have been created in part by Dr. Farouk to help guide clinicians on when it's appropriate to alter doses of these medications depending on their ocular toxicity score. So the ocular toxicity score uses a combination of patients' vision and their corneal exam findings. And if they have, depending on what their ocular toxicity score, these patients may either have to continue on their treatment with monitoring from their ophthalmologist, reduce their dose to a lower dose, delay their treatment, or even terminate their Belamaf treatment. And you can imagine that this presents a very challenging situation for patients because some of these patients don't have any other reasonable options for treatment of their cancer, and it might be their only hope for a potential cure for their cancer. So we take these decisions very seriously, and there's really little information about how often ocular-related side effects play a role into these dose modifications that occur. And that was really the primary focus of our study. The goal was to identify what features actually lead to dose modifications for patients taking Belknap for multiple myeloma, and how often ocular-related side effects play a role in this decision. So this was a retrospective study. It was also multi-center, so we included any patient who underwent treatment for multiple myeloma using Belknap, either at the University of Chicago or at Vanderbilt Eye Institute between January 1st, 2018 and December 31st, 2022. And initially we collected baseline demographic information. We also collected ocular characteristics like vision, intraocular pressure, corneal exam findings, and then ocular toxicity gradings at their baseline examination, and then at any subsequent exam where their corneal exam changed from their baseline. And then we also evaluated what actually led to dose modifications for patients. So specifically, if patients had a reduction in their dose, if patients had to delay their dose, or if they had to terminate their Belknap dose. So this is our demographic information. We had a total of 21 patients in our study, and overall we had a pretty well-rounded cohort. And you can see that 52% of patients developed these pseudomicrocysts after their second round of treatment. 43% of patients had to reduce their dose of Belknap, and actually 89% of the time, this was related to ocular adverse events. However, dose delays only happened about 57% of the time, and only a quarter of these patients had dose delays because of their ocular side effects. In addition, doses were terminated 33% of the time, but only 43% of the time this was related to ocular side effects. So what does this tell us? Well, just like patients who take Tivdak, patients taking Belknap also need close monitoring and close communication between ophthalmology and oncology. And while patients typically do require dose reductions because of their ocular adverse events, most patients do tolerate a reduced dose and can continue on treatment despite their ocular adverse events. And most of the time when patients have a dose delay or when they have to terminate their dose, usually it's not related to ocular side effects. And there's definitely more research that needs to be done in this area. For example, one thing that we're currently investigating is what specific eye findings lead to dose changes. Like, is it refractive changes? Is it topographic changes, etc. So I want to change gears for a moment and talk about my second project. So this was a quality improvement project where we assessed family planning during ophthalmology residency. And I want to thank Dr. Rodriguez and Rebecca Tenenbaum for their support and assistance with this project. So it's very well known in the literature that family planning is a significant source of stress for trainees. In fact, there was a recent article that was published by Dr. Ruth Williams, who's a former American Academy of Ophthalmology president, on this exact topic. And our study really aims to understand why this is and how we can offer a potential solution to fix it. So in the fall of 2024, we recruited any ophthalmology trainee at the University of Chicago to a family planning seminar. The family planning seminar had two components. The first was an educational PowerPoint presentation where we reviewed different topics like childcare options, fertility treatments at the University of Chicago. And then the second component was a physician panel where we had Dr. Rodriguez, our pediatric ophthalmologist, Dr. Nelson, one of our NICU attendings, and Dr. Atelier, who is a OB-GYN at the hospital and specializes in reproductive medicine, who were available to answer questions from the audience. And then we had pre and post seminar surveys that were distributed to all participants. And participants were asked to rank different barriers related to family planning on a scale of 1 to 5, 5 being the most stressful. And we analyzed different medians for matched pairs using Wilcoxon sign rank test. This is our demographic information. We had a total of 8 participants, mostly females, and a good distribution across PGY scales. And you can see from our survey results that our family planning seminar was highly effective in educating participants about things like family leave policies, fertility policies, and childcare policies at the University of Chicago. However, most participants still felt that barriers to family planning were reluctance to miss time in the operating room, financial constraints, perception from colleagues, and also childcare options. And most participants felt that meaningful educational styles to educate trainees about this topic would be lecture-style, PowerPoint-style presentations, physician panels, or a message from our program director. And every single participant felt that this topic would be highly welcomed as a future grand rounds or didactic session. So where do we go from here? Well, hopefully we can continue to have a very positive culture within our department, which I think as a whole we succeed at tremendously. And Rebecca and I are currently compiling all of the different policies at the University of Chicago into a document which can be distributed to trainees both now and in the future, and can be updated regularly as the hospital and department evolve. And then hopefully our educational seminar can be something that is done on an annual basis. So I spent a couple moments talking about some of my favorite things. I want to just briefly talk about some of my favorite people. So I think that everyone in the audience today would agree that it really takes a village to raise and nurture a resident, and I would not be here today without some very important people in my life, specifically my mentors. I'm so grateful for all of your wisdom and support and patience over the past several years. Specifically, I want to thank the entire cornea department at the University of Chicago, specifically Dr. Farouk, Dr. Velman, Dr. Aridi, and then Dr. Shaw, Dr. Rodriguez, Dr. Harry Prasad. I'm very grateful for all of your support, and just really all the faculty that I've had the pleasure of interacting with. I also want to thank the entire support staff and administrative staff. I'm really so blessed to have you have made this time so meaningful and memorable for me. And then I also want to thank my co-residents, especially Dept and Rebecca. I'm so grateful that you all have had my back for the past 4 years and have been there to support me. And I'm so lucky and privileged to have worked alongside such wonderful, diligent, and empathetic people. So thank you for that. We have such good memories together. And then last but certainly not least, I want to thank my family. You guys are all really the foundation of my life, the rocks in my life, the people who really pushed me to be the best version of myself and get through all the hard times that we've had over the past several years together. And I'm so blessed and to have you in my life. Specifically, I want to thank my parents who are here from Florida, Warren and Henny. I also want to thank my in-laws who are here from California, Andy and Yoey. I want to thank my brothers, Shul and Andrew, for their support, my grandma Phyllis, my grandma Pat, my Softa and Zeta, and then my sister-in-law, my brother-in-laws, who are just honestly too numerous to name individually. And then I also want to thank my husband, Avi. We'll actually be celebrating our 12-year anniversary this summer, and my 3-year-old daughter, Rachel. I'm so lucky to have you all, and thank you all so much.